Imagine you're deep in an engine room. It's all hissing steam and the wild, heavy ticking of a dozen clocks, none of them in sync. But underneath all that noise, there's a core rhythm, a steady, powerful beat pulsing through copper pipes and glowing gauges. But you gotta listen close, lean in. Can you hear it? That little stutter, a strain. That's the telltale shriek of metal under way too much pressure. That is a warning.
Okay, so let's get into this. We're not just talking about an organ here. Think of the heart as this insane masterpiece of steampunk engineering. It's a brass and copper engine, right? Powered by steam and bioelectricity, and it's driving this entire fragile system. And just like any machine that's pushed to its absolute limit, it has alerts built right in. Alerts designed to scream before it completely tears itself apart.
And that main warning, that piercing steam whistle that just cuts through all the other noise, that's called angina. So here's the most important thing to get right away. Angina is not the disaster itself. It's the symptom. It's the engine's desperate, howling signal that its fuel lines, the coronary arteries, are failing to get enough oxygen-rich blood through. It is the agonizing cry of ischemia.
Now, if you want to be a master engineer of this biological engine, you have to memorize the schematics of how it fails. You can't just see a flashing light and panic. You need to know exactly why it's flashing, which gear is slipping, which pipe is clogged. So let's break down the different types of system failures, because this is how we build our diagnostic blueprint.
Okay, check this out. This slide is all about control versus total chaos. On one side, you've got chronic, stable angina. Think of this as your known issue, a predictable pressure leak. There's a stable, hardened plaque in the artery. So when you push the engine hard, maybe you climb some stairs or get stressed, the demand for fuel suddenly outstrips what that narrowed pipe can supply. The pain kicks in. But then you power down, you rest, and the pain goes away. It's predictable. But unstable angina? Oh, that is a whole different beast. This is a plaque that has ruptured. It's bleeding, it's forming a clot, and it's threatening to completely block that artery at any second. This is the sound of rivets popping off the boiler. It's unpredictable and can happen even when you're just sitting there. This isn't a warning anymore. This is a full-blown emergency.
And then you get the really weird malfunctions. Prinzmetal or variant angina isn't about a clog in the pipe at all. This is a pure mechanical failure, like a seized valve. For some reason, the coronary artery itself, because of a hyperactive muscle layer, just suddenly spasms and clamps completely shut. It's a functional problem, not a blockage. It often happens at rest, maybe in the middle of the night, and can be triggered by stuff like smoking or even just cold air. It's like a ghost in the machine, because it's invisible on an angiogram unless you're lucky enough to catch it right in the act.
And this is where things get really, really maddening and complex. Microvascular angina is a failure deep in the guts of the system, in the tiniest, most intricate little pipes. The main arteries, the big ones we can easily see on a test, they look totally clear. But the little micropipes that feed the heart muscle directly, they're failing. And this causes very real, very dangerous pain from ischemia. But the big diagnostic tests can come back looking totally normal. It's a super frustrating, sneaky problem that takes a much deeper level of investigation to figure out. So, the warning lights are flashing, the alarms are blaring. How do we, as the engineers, see what's really happening inside all that chaos? Well, we can't just rely on the pressure gauges. We have to tap into the machine's nervous system. We need to read its electrical blueprint. We need an electrocardiogram, the ECG.
And this right here, this is our baseline. This is the schematic for a perfectly tuned engine. This beautiful rhythmic wave is the electrical signature of one single perfect heartbeat. That little P wave, that's the spark firing in the atria. The QRS complex, that huge sharp spike, that's the massive electrical blast that forces the main chambers, the ventricles, to contract and push blood out. And then the T wave, that's the system resetting, the electricals repolarizing, getting ready for the next powerful cycle. This is perfect harmony.
But listen, when the engine starts to sputter, we can't afford to guess. We need a system. This is the engineer's diagnostic protocol, and you follow it without skipping a single step every single time. Is the rhythm regular, or is it all over the place? What's the rate? Is there a P wave before every single QRS? How long is that PR interval? Is the QRS complex nice and narrow, or is it wide and weird? By following these steps methodically, you take a chaotic, frantic squiggle and you turn it into cold, hard, actionable data. And here's the thing. When the engine is starved of oxygen, it leaves clues. It actually etches ghosts into that electrical blueprint. You have to look for these two classic signs. A dip in the ST segment, that's the flat line right after the big QRS spike, that suggests the inner layer of the heart muscle isn't getting enough oxygen. Or a T wave that's suddenly flipped upside down, totally inverted. That's another classic fingerprint of a struggling heart muscle. These are the frantic signals of distress you're looking for.
Just look at the difference here. On the left, you see perfection. It's steady, predictable, powerful. On the right, whoa. That's what happens when ischemia makes the engine electrically unstable. Those wide, bizarre, chaotic-looking beats are called premature ventricular contractions, or PVCs. See, an oxygen-starved ventricle gets irritable. It starts firing off its own rogue signals, totally disrupting the rhythm. These aren't just little hiccups. They are serious signs of instability that could spiral into a life-threatening arrhythmia.
Okay, so we've diagnosed the fault. We've figured out the electrical ghosts that are haunting the machine. Now, it's time to step in. It's time to open the alchemist's toolkit and use the right pharmacological tools to tame this engine before it blows.
First up, the absolute classic, nitrates. You need to think of nitroglycerin as your emergency pressure release valve. It's a powerful vasodilator. It basically opens up all the pipes, which dramatically reduces the pressure the heart has to pump against. We call that afterload. And it also reduces how much blood is returning to the heart. That's the preload. It instantly and drastically lowers the engine's workload, which eases the strain and relieves that ischemic pain.
So this is basically the user manual for this incredibly powerful tool, and the instructions have to be followed precisely. 1 tablet under the tongue. Now listen close. If the pain is not gone in 5 minutes, they must call 911 immediately. Then they can take a second dose. You want emergency services on the way, and you have to warn them, a pounding headache is totally expected. That's actually a sign that the drug is working. And one last thing, for long-term use, they have to have a 10 to 12-hour nitrate-free period every day to keep their body from getting used to it.
Next up in the toolkit, beta blockers. Look, if nitrates are the pressure release valve, beta blockers are the engine governor. Their whole job is to fundamentally slow the machine down. They block the effects of adrenaline, which decreases the heart rate, lowers the force of contraction, and reduces blood pressure. A slower, less forceful engine needs way less oxygen, which is exactly what a machine with a busted fuel line needs to survive.
Now this is critically important, especially for your exams. Since you're putting a governor on the engine, you have to watch out for it working too well. That means bradycardia and hypotension. Always check the pulse before you give a dose. But here it is, the big exam trap. There are 2 kinds of beta blockers. The cardioselective ones, like metoprolol, mostly just target the heart. But the non-selective ones, well, they also block beta receptors in the lungs, and that can cause severe bronchoconstriction in patients with asthma or COPD. It is a fatal error that you absolutely cannot make.
And finally, we've got calcium channel blockers. Think of these as the system lubricant. They relax the smooth muscle in the blood vessels, which causes vasodilation and lowers blood pressure. But some of them, like verapamil and diltiazem, also slow down the electrical conduction through the heart, so they kind of act like a second governor on the heart rate. They just make everything run smoother, reducing friction and the overall strain on all the engine's moving parts.
So let's do a quick recap of the toolkit. Nitrates are your pressure release valve, and they help reduce those electrical signs of ischemia. Beta blockers are the engine governor, and they'll show up on the ECG as bradycardia, a slow heart rate. And calcium channel blockers are the system lubricant, which can also cause bradycardia or, if they slow things down too much, even a dangerous AV block. Every tool has a job, and every tool leaves its own signature on the electrical blueprint.
All right, you've studied the old, cracked schematics, you've learned how to decode the electrical ghosts, you have mastered the alchemist's toolkit. Now, it's time for the final exam. These are the code-red, high-stakes scenarios where your knowledge is the only thing standing between keeping the system stable and a catastrophic, all-out meltdown.
Okay, first scenario. Your patient is on a long-acting nitrate to keep their system pressure stable and under control. A new order comes in for sildenafil. You probably know it as Viagra. As the engineer responsible for this machine's integrity, what is your absolute #1 priority action?
You question that order. Immediately and forcefully. This combination is an absolute disaster waiting to happen. Both nitrates and sildenafil are powerful vasodilators. You put them together and you get this synergistic effect that will cause a catastrophic, profound, and potentially fatal drop in blood pressure. The pipes just open wide and the pressure plummets to 0. This is a critical safety check you can never, ever miss.
All right, next scenario. A patient is grabbing their chest, that classic substernal pain. You get them on the monitor, stat.
Where, on that PQRST waveform, are you focusing all of your attention to find the very first electrical evidence of myocardial ischemia? You are hunting for the ghosts in the machine, and the hallmark signs of ischemia always show up in the ST segment and the T wave. You want to know why? Because that phase of the heartbeat represents ventricular repolarization. That's the heart muscle resetting its electrical charge. It's the most energy-intensive part of the cycle, so it is the very first thing to fail when the oxygen supply gets cut. An ST depression or a T-wave inversion is literally the electrical scream of a suffocating heart muscle.
And really, this is what it all comes down to, right? The gauges are buried in the red, the alarms are a chaotic symphony of failure, and the entire engine is shaking itself to pieces. But you are not just watching anymore. You have the schematics. You can read the ghostly electrical code. You hold the alchemist's tools. The only question left is the one you're going to have to answer every single day. Can you master this beautiful, violent, chaotic machine and intervene before the system goes critical? The answer is yes. Now you know how.